In addition to the national patient safety goals we've described, the Joint Commission has also developed the Universal Protocol for Preventing Wrong Site, Wrong Procedure, and Wrong Person Surgery. Errors of this nature are very infrequent, but when they do occur, they can be tragic. The Universal Protocol consists of three major requirements. First, the institution must implement a preoperative verification process to discuss and confirm that all appropriate documentation, including the patient's history and physical, operative consent, lab results, X-rays, and other images are available, correctly match the patient, and are consistent with the patient's expectations before any surgical or invasive procedures are performed in all settings, including bedside. Verification of the correct person, correct site, and correct procedure is an ongoing process and should involve the patient if possible. Any discrepancies or missing information must be addressed before beginning the procedure. In the last verification in the pre-procedure area, immediately before transfer to the procedure room, a standardized list should be used to verify that the following items are present: all relevant documentation, including nursing assessment and pre-anesthesia assessment, a completed and signed consent form, all diagnostic and test results, including images and scans that are properly labeled, and any required blood products or special equipment for the procedure. Second, as part of all procedures that involve incision, puncture, or insertion, the institution must implement a regular system to physically mark the operative site with a permanent marking that will not be removed during surgical prep. A defined procedure must be in place for instances when a patient refuses to allow site marking or site marking is impossible, such as on mucosal surfaces, on premature infants, or procedures where the site is not predetermined. The mark itself must not be ambiguous, such as an X. The mark used should be universal throughout the institution. The marking is to be performed by a clinician who is directly part of the team that will be performing the surgery, and the marking must occur before the patient is moved to the procedure site while the patient is still conscious and can be involved in the process. In limited circumstances, the marking may be delegated to another participant in the surgery, an advanced practice nurse or physician assistant who is familiar with the patient and will be present during the surgery. Mark the surgical site with Y for yes, or a line to indicate the incision, and preferably add your initials. Do not mark non-operative sites. Adhesive site markers are not to be used as the sole site markers. Organizations are allowed to develop alternative processes for site marking. For spinal procedures, in addition to the general site marking, special intraoperative radiographic techniques are used for marking the exact vertebral level. For a tooth, the operative tooth can be named and numbered in documentation or marked on a radiograph, as long as the document or radiograph is available in the procedure room. For minimal access procedures, entering percutaneously or through a natural orifice, the intended side can be indicated near the operative site. The third component of the Universal Protocol calls for taking a timeout immediately before incision or before starting a procedure. During the timeout, the team should focus primarily on assuring the correct patient, the correct procedure, and the correct site. The timeout should be standardized throughout the facility, should be initiated by a designated team member, and involve the active participation of the entire team. There should be a defined process for reconciling any differences in responses. During the timeout, other activities should stop, except as necessary for patient safety, so all team members can concentrate on the verification procedures. This process should be documented, and no procedure should start until any question or concern is resolved. If there are 2 or more procedures to be performed, there must be another timeout before each subsequent procedure. One further requirement relating to the Universal Protocol is the need for facilities to adapt the 3 components of the protocol to non-operating room settings, such as emergency rooms, GI labs, radiology suites, newborn nurseries, labor and delivery rooms, and bedside procedures. Compliance with both the Universal Protocol and the National Patient Safety Goals are required by the Joint Commission. Every single patient who enters a hospital deserves to receive the appropriate care that will improve his or her condition or alleviate pain without the intrusion of mistakes or medical errors. The Joint Commission's Patient Safety Initiative is designed to set up a framework and take the first major steps toward assuring that all healthcare institutions meet this goal for their patients.